So one thing, another study that got a lot of press at ASCO and a lot of press at the AUA was the mechanisms of drug resistance, especially in patients who are on these secondary hormonal therapies, abiraterone acetate and enzalutamide. So the folks from Johns Hopkins presented some data looking specifically at one of the, again, proposed resistance mechanisms to these therapies, which is the presence of the androgen-receptor V7 splice variant. Neil, can you walk us through that trial?
Sure. So it was a really nice paper by Emmanuel Antonorakis. It just got published in the New England Journal, if anybody wants to go and look at it, just last month. So essentially, if you think of the androgen receptor, there's what's called the ligand binding domain. And there's an N-terminus and a C-terminus. And essentially what happens is there's a deletion on this ligand binding domain so that you really don't need androgen to stimulate as the ligand. You don't need that anymore to stimulate the androgen receptor. That's essentially a simplistic way of thinking about the AR-V7. And so the receptor just gets constitutively activated. And that explains why, depending upon your study, that if looking at abiraterone or enzalutamide in patients who are naive to either one, that about anywhere from 10 to 20% of patients don't see PSAs go down because there's probably already some sort of splice variant, most likely the AR-V7, and there's probably going to be others. As we see patients who get Abi first and then docetaxel and then Enza, or just even Abi to Enza or Enza to Abi, that number of patients whose PSAs will not respond goes up probably from 20 to 40%. That's now acquired resistance as opposed to primary resistance. And there's just, beautiful work being done by, labs such as Ganesha's and Johns Hopkins and others looking at these splice variants. And that's why none of these drugs end up in cure. This is why patients ultimately progress. So it's a problem, but it's a great time because the pipeline is so rich now with other therapeutics that may have better impact on these patients who have the variant present either initially or later on when they get it acquired.
Yeah, I know. If I might, I think just exactly what Neil said. We were talking about biomarkers at the very beginning, and this is a very robust predictive biomarker, predicted treatment response. And I think the study, as Neil suggests, is really informative on many fronts. One is that it really tells us that the harbingers of CRPC, castrate-resistant prostate cancer, are at least in a subfraction of patients there from the get-go. So there's acquired resistance, as Neil said, but also there are a fraction of patients, 15% or so, who already have it from the very beginning. Secondarily, this was an assay, a molecular diagnostic test done by PCR from circulating tumor cells. So it's a very hot topic these days, sort of measuring circulating tumor cells as a surrogate for burden of disease, maybe also predictive and prognostic. But these researchers were able to isolate these, which is no easy task, and then interrogate these cells for these AR-V7 splice variant. And they found that it basically was a binary outcome. If you had the V7 variant, you didn't respond, and if you didn't have if you did have the splice variant, you didn't respond. If you didn't have it, you did respond. It's really an amazing study. It needs to be replicated and really validated in other large groups, but really points to what we were talking at the very beginning about biomarkers and really precision medicine, right? So we're now not only treating diseases, we're not only treating patients, we're treating a patient's disease and really trying to interrogate in a very specific way what alterations are driving their disease so we can then target that particular disease in a very specific way. So I think probably, as Neil said, it's an exciting time to be in this space, and we're going to see as many more diagnostics sort of explode in this space, more therapeutics will be able to probably be assigned in a more refined manner. Then sort of like one hammer hit everything. Now we're going to know you got a nail, you got a screw, so we're going to put a screwdriver here, put a nail here, or put a stapler there, something, So be much more refined, and it's really an exciting time.
Ganesh, are you guys doing a lot of tissue or bone biopsies? Because to me, we're throwing things at these patients, and we're just making some assumptions. We also know that unfortunately, once these tumors get out, we know it in bladder, that they're going to look entirely different at the Met.
Yeah, so we are. I mean, we're very fortunate enough to have one of these Stand Up to Cancer, American Association for Cancer Research grants, partnered with the PCF. Arul Chennai is the global leader for that. He's at Michigan and is part of our group. So we're able to kind of get longitudinal biopsies. Bone biopsies are a little bit more challenging to get. We're able to actually get some enough tissue to actually examine and investigate. Also soft tissue met. So really, that's part of that our group Stand Up to Cancer grant, is to really chart the natural history of prostate cancer in the metastatic space as resistance to therapies develop, and really interrogate the genetic alterations and see the evolution of the disease as it goes on. But I think, to go back, I think an age-old question was, is the chicken or the egg? Were you born with CRPC from always, or did you acquire it? And I think for some, they had it from the beginning. And my suspicion is that at some point in time, there'll be a fraction of patients who have metastatic disease where we won't give ADT first, because we'll know that that in fact may actually accelerate the disease. But I mean, time will tell.
See, I think this is where, especially those of us that do a lot of clinical research, and obviously the beauty about the integrated practices that we have set up is to work in conjunction with our academic brethren, where if you think about it, we could devise a study where, because we have the cores, we could also access the radical prostatectomy specimens, and because we have the longitudinal data, do the biopsy and can try to piece all this together. Is, can we find this 20%? What are the characteristics? Can we find this 20% that may have the variant, up front? So.
And even people with metastatic disease, different metastatic locations can have different genetic variations, so it's just immensely complicated.
Right.